suppose I should introduce the topic, the idea of social prescribing in a digital world. With the COVID pandemic, there's been massive changes, certainly across Ireland. I presume that's been reflected across England as well, and the rest of the other nations. We've moved very much to digital provision and digital linkage with our clients, and it's been a real challenge. And there's been a number of common themes that have emerged in our practice. The idea of digital inequality has been huge, and we want to see if we can kick off with Muir's presentation, and I will cue you when to start looking at the videos. The links to the videos are going to be posted every few minutes in the chat at the side. There's 3 video presentations. The total there is about 20 minutes. So I'll cue you to start looking at them, and we can reconvene about 25 minutes later in this chat room.
David?
Yes, do please start. And I said I'll reintroduce the videos then when you're finished.
Can you see the revolution?
Yes, you can.
Good. Okay. Ladies and gentlemen, I'm very sorry to be late. The link wouldn't work. One of these great phrases like "you're on mute," which will be with us as a result of this year. So I'm very pleased to be here. And I'm going to tell you about what we're doing with social prescribing for people about living longer better. And we're using social prescribing for a revolution to think in a completely new way about living longer. I speak as someone aged 76 with multiple conditions of one sort or another, fairly typical 76-year-old. So here's the new revolution. Here's what we want to achieve. To appreciate that aging by itself is not a cause of major problems until the late 90s. So there's 3 other things we need to do to regain and improve fitness, physical, cognitive, and emotional, prevent and tackle disease, and most important of all, perhaps, to think positive. So what we've done is not to try to change the structure of health and social care. And I'm now in the midst of my 28th NHS reorganisation, most of which has made no difference at all. And we're using what we've used before in developing screening programs and other long-term condition programs, much simpler than population aging, less complex, but the same principle. A system is a set of activities with a common set of objectives. And here are the objectives that we're setting out. And this should be relevant in every country, I think, because the processes that are taking place are the same. But we're promoting this across the whole of England, and we've got about 20 million of the population covered. And you can see they range very widely from fairly obvious objectives like to increase physical ability and resilience and health span, to more complex, like to mitigate the effects of deprivation. And then the last one there, we're still discussing the wording. Is it to reduce the risk of a bad death or to enable dying well as living well? So positive as well as negative. Systems are delivered by networks. You need structures for linear tasks like the fair and open employment of staff. But this is the century of the network, and social prescribing plays a key part in developing the network. And what we're planning to do is to issue prescriptions. Now, this is in a way quite a narrow bit of social prescribing. I'm focusing on activity, but that's physical, cognitive, and emotional. So we now have a GP system set in England where we can measure how much people walk. They can put it in. They can take their Active 10 app, measure how many minutes they walk briskly, and they can feed it in. And we can link that to their BMI, and link it to their diagnosis, and link it to the prescription. So we're prescribing walking. We're also prescribing more activity related to strength, suppleness, and skill. We always say the 5 S's of fitness are strength, suppleness, skill, stamina, and psychological. And the room laughs politely. It's the 5th S. So we're now starting to use social prescribing to link people to local services or to online services like the EXA service set up by 2 young physiotherapists. But again, we depend on social prescribing link workers to provide the GP information systems with information about activities within 2 miles of the health centre. We're also prescribing high tech, and at the top you can see a new type of treadmill that doesn't move. It's very safe. The people's feet slide, so people could start walking in groups. Here's people walking along the Great Wall of China in a group, and I hope raising money for a good cause like the Oxfordshire Wildlife Trust. And I hope competing, so the Oxfordshire walkers could compete with the Cambridge walkers. And the lower picture is a bicycle, which can also be used with virtual reality to engage people in groups. And we can now share what someone is doing. They can share it with their relatives, even if the relatives haven't got virtual reality. So you could go walking with your niece in Calgary, or walking with your sister in Inverness, chatting as you go. So this is what is part of the cultural revolution. And therefore, we want social prescribing to be part of a revolutionary process. And to bring about a revolution, you need a bit of instability, which COVID has given us. We need a new language, so we're stopping using the word retirement. We call it renaissance. We don't like the word care, which means doing things for people. We're calling it coaching. We introduced the word purpose. For everyone over 60 needs purpose. Then we've got an online learning program. We've got to rewire the brains of people. So we're using social prescribing to offer learning. And we'll, of course, we'll have to increase digital inclusion. And that's part of getting everyone online, just as we got everyone over 60 on the telephone 50 years ago when I started. And the key issue, maintaining strength of purpose. So digital inclusion plays a very important part in our social prescribing initiative. And here's an example of the sort of things that we're doing. I did a podcast on Tom Muir, and it was very good. He showed the benefits of walking, but he also showed the benefits of purpose. And this chap on the right is 94. He couldn't get out of his chair, but he's now standing up every day to raise money for the Oxfordshire Wildlife Trust. And his standing performance, we may even get him walking again. And he's motivated by the sense of purpose for the Oxfordshire Wildlife Trust. So thank you very much. And I will now pass back to my co-chair and look forward to hearing the other presentations.
Hello, thanks and welcome back. There's been one question there, but I think what I will do is defer all the questions and we can deal with them all together.
Yeah.
And when we've finished watching the videos. So if Ben could just repost that video link for those people who've just joined. It was last posted 4 minutes ago. So you'll see there's 3 videos to watch all together. In order, Rachel Hatfield is the first presenter, and she's presenting from Digital Technologies and Health and Social Care. She's presenting on the Social Prescriber Digital Upskilling Program, which might address one of the comments that was posed there about the different levels of care. Secondly, there's John McGuinness and Anant Jani. Anant is on the panel as well as John today. They're going to present the RCGP's perspective on social prescribing using some really interesting observational data. And then lastly, Rachel Bennett is presenting with Andreas Johnson and Sally Payne, who are clients of the Brave Art program in Suffolk. So in total, it's about 20 minutes of video.
Hi everyone, and welcome to our presentation on the use of digital technologies in health and social care. So this presentation is going to be talking about the work that we've done with social prescribers to introduce them to accessible modes of digital technology to enable them to empower their patients more. So I'm Rachel Hatfield and I've been the programme manager for this piece of work.
I'm Anne Hughes, practice nurse and clinical support.
And I'm Alex Rowley, digital lead and technical support.
So fitting in with the digital first agenda, we've been focusing on upskilling social prescribers. So we've been encouraging our social prescriber professionals to use the tools that are readily available both in primary and social care and promote these technologies to their patients and service users in order to embed them. This has allowed them to develop within their role and also to meet the needs of the healthcare system and encouraging patients to use more digital tools. Digital technology is changing health and social care, and as a result, NHS England and social care organisations are supporting a move towards a digital first approach. This is where patients and service users can easily access the resources that they need using digital and online tools. This means that all patients and service users should be able to access all primary care and social care services. This includes receiving advice, having a consultation with a health or social care professional, and ultimately empowering the person by signposting them to accurate, reliable and trustworthy information as required.
So in order to achieve this, we discuss 4 core modes of TECS, that's technology-enabled care systems. So we discuss video calling and conferencing, social media and health apps, and assistive technologies.
Why would we need to use video calls in our role as social prescribers? Well, it's convenient for all. That's both the social prescriber of patients, service users, and also it's well documented that it's easy to build that essential rapport when they can see you smile. But furthermore, you're able to pick up on visual cues that you would be hidden with a simple telephone call. So that makes this a really valuable tool. So social media for communication, and lots of you will be attached to practices or PCNs that already have a well-established social media presence. And by this, I mean it could be a professional Facebook page, it could be Instagram or Twitter, or indeed all 3. Social media platforms are a great way to get your accurate, reliable information across to your patient groups or your general public even. The general public use social media sites, and this is a quick, convenient way to reach out and offer help and support that's recognised.
We stress the importance of social media and the need for people to be able to gain reliable, accurate information. As you can see from this quick infographic on screen, a lot of people are now using social media to get their information. In 2019, it was 49%, and of course, that's rising all the time. So it's our job and responsibility to ensure that is accurate.
We've also been recommending the use of apps and websites for social prescribers to recommend to their service users. There are many free apps and websites available that can be easily accessed that can help with health conditions, relaxation techniques, stress management and mental well-being.
It's important again for us to recommend and stress the importance of getting this information from reliable sources. So it's not about us teaching on all the apps out there, there are thousands, but we signpost and discuss the need for that accurate information. And that's perfectly illustrated by this slide, whereby the NHS Smoke Free, there were 2 apps on the App Store, one's the genuine one and one's the counterfeit one. So it's just about us acknowledging and ensuring we are correct in what we say and share. We also acknowledge that core digital literacy is a barrier with all our service users and people we engage with. So we try and stress that this doesn't have to be as much of a problem as we think. There are ways to teach and educate people and help them through this barrier. There are plenty of support groups and services and organisations out there where they can get access to training and equipment and skills and expertise. And there is a great site by the Good Things Foundation called Learn My Way, which if you guys haven't checked out, you should definitely have a look at that. So moving on to digital assistive technologies, again, bridging this barrier, this digital divide, we have found these to be fantastic devices. Now, we aren't promoting that people push these out to homes and supply these as part of the health agenda, but we're about acknowledging what is already in people's homes. They're fantastic for helping with frail and elderly, people with mobility challenges, as well as long-term health conditions such as asthma, COPD, dementia and heart conditions. We've also found they're fantastic for helping with people's mental health and well-being.
So now we're just going to present to you some of the findings we've had from the cohorts that we've worked with. So as you can see from the graph, we've managed to increase the use of digital tools for the social prescribers with their service users. So we've focused mainly on video consultation, social media to engage with service users, promoting apps and websites to support health and well-being. And you can see the improvement that people have got just from attending the course. For us, it's very much about the encouragement and promotion of these digital tools to the social prescriber professionals, and showing them how they can work them, what the benefits are for both them and for their service users, and encouraging them to take an open mind and embed them within their role.
And we're just going to leave you with a beautiful quote from one of the social prescribers we had the privilege of working alongside. And it perfectly demonstrates how having the opportunity to learn new skills, discuss, and having that time to just think really on about embedding them into their workplace has gone a long way.
Thank you all for your time today. We hope you've enjoyed our presentation. And if you'd like to find out any more about the work that we've been doing with social prescribers, and that's also taken place with clinicians and social care workers, please feel free to get in touch. Thank you.
I might just tackle some of the questions while we're waiting for the next video to be lined up. Are there any specific video platforms that have been found to be best used? Has been asked by Caroline Biggs, and that's been one of my questions actually. Is there a universal digital platform that can underpin all of these? Because otherwise you're asking people to log into multiple different apps and multiple different devices. I see that you've used Alexa in your digital upskilling program, but I wonder, is that a universal thing or is it just local to your project?
It's Muir here. I think we have to accept that we live in this. Anyone who thinks they're managing the internet has got a delusion. So there's going to be a range of things. In the technology, we're looking particularly at Alexa and the Facebook portal. And as a hopeless typer, I'm really looking forward. I don't have a Facebook portal yet, but I think none of us will be typing in 5 years. So that's a move. And then on the actual portal side, I think we're relying on communication from the primary care team, and the fact that something's recommended by the primary care team. And this is, of course, just for that's easy for local physical activity, but I think it's difficult to manage it much more precisely. And a very good question was asked about different levels of art therapy. We'll need to let people find their own level. Again, one of the great things is about this thing called the internet. And remember, Tim Berners-Lee said in 2000 his 10-year objective was no one would use the word the internet. Then people can click, click, click and go into more details. So I don't think we should make assumptions with people. We should start with something simple. And I find that healthcare professionals often prefer something simple because time's their problem. And the people we call patients have got more time and they want to go into more depth.
Super. Just addressing some of the others, the financial digital divide and connectivity. We might leave that to the end when we're at the panel, because it's a huge topic, which is probably common to all of the presentations. Regarding the message notifications, I presume you can mute them locally on your own device or machine. I'm not getting any message notifications. The chat is in the side, and with respect to the digital divide and connectivity and skills of older people, that was actually a question of mine, where if you found, because I think we all reach an age where you start giving off a field that just interrupts electronics around you, nothing to do with your individual skills. In terms of older people adopting these technologies, is there much resistance? What we found locally is that it's the grandkids in the family. Yes. Introduce the older people to it.
Yeah, people don't like their children telling them what to do. Our original plan was to get the cadets and the Boy Scouts doing it pre-COVID. Of course, that's been a bit knocked on the head at the moment. But we just need to keep saying that the internet is easier than a washing machine. I mean, if you look at the modern washing machine, the controls are Byzantine in their complexity. So it obviously we won't get everyone online, but I think we just need to keep saying we all forget it. You know, this is just like running your cooker or the timer in your cooker. Now, some people can't organize a timer on their cooker because of dementia, and that is an issue. But that's again where the Facebook portal is very good, where we just use the voice and speaking, and that I think at the moment I've got an Alexa, but I think the Facebook portal is more usable than Alexa.
Yes.
Hi there, my name's John McGuinness. I'm a GP in South East London, and I'm working with the RCGP as a clinical champion working on a social prescribing observatory project. And over the next few minutes, we're going to hear from myself and my colleague Anant about how we can use excellent resource. So some of you may have heard of the RCGP RSC. So it's a research sentinel network, and it covers over 1,800 GP practices across England with a population coverage of up to 8 million. And they do some amazing research and produce some dashboards. And if you are interested in signing up to the RSC, then do look at their website. But recently, they've launched a social prescribing observatory and practice dashboards, which is a really powerful resource so we can look at social prescribing activity. So to learn more, I'm going to pass over to my colleague Anant, and then we'll come back to me about how we can use that practically.
Thanks very much, John. My name is Anant. I'm a research fellow at the University of Oxford, and I'm going to show you a few slides which give an overview of the Social Prescribing Observatory.
Anant's on the...
as John mentioned, the Social Prescribing Observatory is a collaboration between the University of Oxford and the Research Surveillance Centre at the Royal College of GPs. And it captures data on a weekly basis and displays information about social prescribing utilization, broken down by different demographic characteristics: age, gender, IMD, ethnicity, and ICS. So here's a link to the observatory. It's all publicly available. And looking at some of the data that we've collected so far, if we look from January to September 2020, we know from the RSC that there have been about 250,000 social prescribing referrals across England. And what this heat map demonstrates, it's broken down at ICS level, and it shows the rate per 10,000. So that's the number you see within the different ICSs across England. So this is the rate per 10,000 of social prescribing referrals. And then we've also looked at referrals based on different demographic characteristics. So IMD, Index of Multiple Deprivation, which is an indicator of socioeconomic status, with IMD 5 being the least deprived and IMD 1 being the most deprived. And what we found was that there was a lot of variation between the different ICSs, which is indicated by these error bars. But there's not that much difference when we look at the rate per 10,000 across the different IMD quintiles. Then we also looked at ethnicity. So we have Asian, Black, Mixed, and White. And again, we see a lot of variation across England between the different ICSs, but we don't see too much of a difference between the Asian, Black, and Mixed, and we do see that there's more referrals for White. What we do note is that there's no statistically significant difference in the rates of referral by either gender, ethnicity, or IMD. And then finally, in terms of looking at the demographics, we have age. And here we do have a statistically significant difference, with the over 65s getting way more social prescribing referrals than any of the other age demographics. And again, we see this high level of variation, particularly for the over 65s. Now, one of the key points to keep in mind for the Social Prescribing Observatory is that the data that we put out is only as good as the data that's put in. So that's why it's so important to improve the quality of coding and the data that's actually recorded when you're socially prescribing to individual patients coming to you. And that's one thing. The second thing is, because it's updated on a weekly basis, the Social Prescribing Observatory can be used to facilitate a learning health system approach. So what that means is that you can look at the data within the Social Prescribing Observatory at a given time. You can identify gaps in your social prescribing practices. Say, for example, you're not giving that many social prescriptions to 0 to 17s. You can create an intervention to try to address that gap, and then 2, 3, 4, 5 weeks later, you can look at the observatory to see if there's actually been a difference. But again, that difference will only show up if the quality of coding is good. So you must record your information in order to see it in the observatory. With that, I'm going to hand over to John, who's going to walk us through how he, as a practicing GP, uses the insights within the observatory.
Thanks, Anant. So hopefully if you can click on the link which we've shared in the chat, it will take you to the heat maps or the line graphs here. And just to talk you through it, so here we've broken it down by our ICS, so focused on where I practice in South East London. And then we've looked at specifically Black and Asian, because we know it's really important that social prescribing is available for everyone. And this can be used as a tool to see, what is the activity in our ICS, who are we not reaching? And we can see the trend over the past beyond 12 months and look at certain peaks. And we've highlighted the graph here. When you hover over the graph, you can see the number of recorded events per population, and it gives you the rate per 10,000. Next slide, please. And again, here we've looked at index of multiple deprivation, because we know, or we would expect at least, that social prescriptions would be higher in the people who have the most need. So thinking about the lower quintiles of index of multiple deprivation, so 1 and 2, we can see their trends on the graphs here. And then if we add in the least deprived, so 5, we can see that the trend is that they have lower social prescription uptake, which I think is right. So I would encourage you to go and click on the link and really have an explore of your local area. We really want it to be useful, as Anant said, as a learning health system for GPs, for link workers, for ICS, for commissioners. And as Anant said, it's really important we use the right codes. So that's the SNOMED codes for social prescriptions. It's a really powerful tool. We need your feedback. It's based on good quality data, and it gives us a national picture of what is happening currently. So really looking forward to taking your questions, and we'll leave it there for now. Thank you.
That's great. Thank you very much. For the last video presentation, we're going to take questions at the end. Rachel Bennett is a learning support tutor who's going to present the project Brave Art in Suffolk. And there's 2 service users, Andreas Johnson and Sally Payne, are going to participate in that also. So I think Ben is lining up that video for us to watch.
Thank you to the chair for that introduction. So, Brave Art. Up until last March, we were delivering face-to-face sessions in Ipswich, in Bury and Lowestoft, and then the pandemic happened, and then we had to rethink. So initially, we felt connection was the most important thing, so we set up wellbeing conversations on the phone, WhatsApp groups. We harnessed the power of Facebook and really raised the profile of our page, using it as a centre to set challenges for students so that there was a focal point. And then the students became in charge of that, and they set their own creative challenges, so it provided a bit of an anchor in the week. But then very gradually we started to realise that something more was needed, and this wasn't going to go away. So we started introducing Zoom sessions and delivering our work over Zoom. So we're going to hear from Andreas, who was an existing student, and Sally, who was a new student, and they're going to talk us through their experiences of Brave Art and specifically accessing art on a digital platform.
Hello, my name is Andreas Johnson, and I am one of the Brave Artists from the Berries and Admins group.
Okay, Andreas, when lockdown started, how did you feel?
I felt nervous and frustrated. I couldn't see any of my friends going out for a drink or having a giggle or a really fun laugh.
Okay, so what kind of challenges did Brave Art give you?
The challenges what Brave Art gave me was like reporting at my brother, like reporting at Mansfield Beach in North Norfolk, and reporting at Sheringham to see trains from Sheringham to Holt and back. And even I've been reported from the Hughes all the things I've done we're making through Brave Arts.
Excellent. And how do you feel about the Zoom meetings?
I was very scared to start with Zoom meetings, but now I can out my shell a lot more now. Talking to my friends, even my support worker Sam, so they know what they've been doing during the week or what they do at the weekends.
Good.
Right, Sally, can you introduce yourself?
Okay, yes. Yeah, my name's Sally. I'm 32 years old. From Suffolk.
Sally, you've got a diagnosis of something, haven't you?
Yes, and my diagnosis is autism.
And when did you join Brave Art?
I joined Brave Art in September 2020.
And how are you finding the Zoom sessions?
Yeah, apparently Brave Art has been done face to face, but since I've been on it, they've been doing it on Zoom. And for me, actually, because I have social anxiety, doing it from home, where I feel more relaxed and can be under a blanket or with a cup of tea. That helps me feel better instead of walking into a room and meeting people properly. Yeah, I still like to feel like connected and part of a group and have fun. And being involved in Brave Art has really given me that. And it's something I look forward to every week. It gives me structure. And yeah, I've been finding it really fun.
It has been a steep learning curve, there's no doubt about it. And we would never have thought that we would have to translate our face-to-face course with 40 plus very diverse learners into a digital platform. But it just goes to show that anything is possible, and we always try and maintain a can-do attitude at Brave Arts, and we believe in celebrating ability. The whole team have pulled together, and that includes the students, the volunteers. We've got students who are on placement with us. We've got parents who are involved. We've got support staff. And the Brave Art community has had to really pull together and make this work. And our artists have really had to step it up and deliver their sessions digitally in a way that's relatable and accessible. So moving forward, using the digital platform has been a positive, and we hope very much to embed it into our future delivery of any projects that we do, because as Sally said, it has really ticked a box for her, and many others like her would benefit from this kind of delivery. Thank you very much. I'm going to hand back to the chair now.
That's great. Thank you very much. That's all the presentations. So there's been a number of questions have been put up in the side chat. Can I ask the panel members just to turn on their cameras and unmute their microphones so they can participate? That's brilliant. Thank you very much. Hi, everybody. So hello. So just going in some reverse order there, in terms of the questions that have been raised, quite a bit of chat about the observational data from the observatory in terms of breaking it down to borough and in terms of what else can be accessed. Can you talk about that for a minute? You can see you've addressed some of it. You've addressed some of it in the side chat there, but the issue of privacy and GDPR have come up. It's really a very tool.
We cannot present practice level data publicly. The lowest level of granularity we can demonstrate at ICS level because we can't be allowed to, I guess, identify the practices. That said, if you are a member of the RSC network,
get down to practice level data, but it's generated a lot of interest, and it just goes to show the power of recording all this information. I think privacy and GDPR issues were raised. As part of that, Liz Lovett raised the issue of having challenging conversations with unseen people in the room. I'm not sure if she was talking about this chat here. You're muted there. Do you want to unmute?
If I could deal with the GDPR,
that we've got NHS Digital very closely involved in our project, and it makes it much tougher, but we're getting it signed off. That's communicating with the GP, but we're also looking at ways in which the GP systems could communicate with, supposing you were a member of a walking club or a gym, for a well-being record. And of course, even GP systems don't communicate with the systems of, say, a community trust. So if you type 2 diabetes, you might have data in the community trust and your GP record. So we've got NHS Digital working on our project. We launched in London this week, and we're certainly making sure that we're conforming, ticking every box.
Okay. There's questions there about digital delivery to older people who don't understand or want to understand technology. We discussed that a little bit in terms of younger family members, and also in Ireland there's a not-for-profit charitable organisation called Alone. They've launched a platform on Alexa, but these are specific to different products. In my house, we can't use Alexa. We use Amanda instead, because Alexa's listening all the time. Does anyone on the panel just want to address that about, in terms of digital upskilling? We talked about upskilling the social prescribing link workers, but what about upskilling the population at large? Because that's just one aspect of digital accessibility.
I think the key for me is the future of the library service. And I'm a great fan of librarians, and I always ask them, are you in the real estate business or the knowledge business? Now, up to now, we've been in the real estate business, running libraries. And very few libraries take action when someone stops coming. But I think the key here, I don't represent any librarians here now, but I think librarians are the key. And they should probably shut the libraries for half a day, so librarians could do much more linking out through church groups and bowls clubs and bridge clubs and a whole variety of networks to reach people. So librarians are of vital importance.
That's a good point in terms of aging and taste as well. Libraries would be key infrastructure. Does anyone else have any comments on that particular issue of digital upskilling?
There's recently been chatter about seeing digital literacy as a new social determinant of health, which I think many of you guys are probably familiar with that kind of rhetorical stance. And I think it's probably true to Muir's point that he made earlier on, that when he started in the service, that their task was to get people on telephones. I think we will have a similar task now in terms of digital upskilling. So I think this probably does need to be seen as a social determinant of sorts.
I remember when we invented the book, we had an awful job getting people to use books. But I've seen these changes take place.
Can I just say we've certainly found it a challenge with some of our older participants in being able to access digital platforms. So we have really had to revert back to old school. And your point about the library, a few of our participants, the library is their go-to place. So not having that has been really difficult. And I think, the potential for libraries to connect and support people, older people on their own who don't have the grandchildren, to provide services is a real move forward.
See, there's some suggestions in the chat there on the side, including a thing called Grandpad. We're not all granddads, those we age. Also, there are specific tablets for older people. I think in terms of digital inequality, we've seen access to the broadband, the technology, skills seem to be the three.
The
three issues. And there's a couple other things there, Sparko TV. One comment is collecting digital literacy or access data on SP service users. Is anyone in the panel aware of any of that? I don't think we're collecting data on that on our own social prescribing project in St James's.
My experience has been that if people like me who don't understand how digital works can describe clearly what we want, the clever digital people can do anything. So we are now getting people learning in groups of people they've never met before. And we said, well, look, what we want people to do is to be able to chat to one another quite easily without going through bloody Zoom or Teams. And the digital people said, yeah, that's easy. And the other thing, of course, is with virtual reality, that I can always tell who's got teenage boys if I use the word fortnight. Half the room goes white in the face about fortnight. But with the software, if that's still the appropriate word behind a fortnight, it's very easy now to organise people going walking trips together around Port Meadow, Oxford, or through the middle of Venice with friends. So I think the important thing for us, people like most of the people on this call, I suspect, is to describe clearly what we want, take into account the social and ethical and other practical problems, and then help other people get online. And the digital people will, in my experience, anything I say, they say, yeah, that's easy, we can do that, providing you deal with the political and the bureaucratic problems.
Would anyone agree that it's this part of the role of the link worker in terms of, I mean, the whole point of the link worker is to connect with available services. And I know in our first social prescribing project in Ireland, which was in Donegal, it was remote and rural. One of the first steps for some people was to provide taxi fares or driving lessons so that they could access the various resources. So there's a kind of digital analogy here. If the link worker has a role in either pointing people to educational services as digital education as a first step, or broadband, that's.
David, yeah, I would agree. I think it's fundamental that link workers, one, are digitally enabled themselves. So we know there's challenges with PCN link workers who, when they've started their post, have not had access to a laptop, to a mobile. And equally, they need to have the skills to teach on to their service users and patients to link them into the correct resources. I think my real concern at the moment is that I think we still see digital as a barrier, and it is a barrier. So even looking at access to general practice, we know, that's been disproportionately affected the most vulnerable groups. The fact that we are now on a digital first model, and I think that is the case for link workers. But it's really encouraging to see where digital has been used as an enabler, like that that short video with Andrea and the impact Brave Art had on him was phenomenal, because I know in GP practice, and again people will have similar stories, that for people who have complex needs, when the pandemic struck, their support structure was completely wiped out. They're going to the day centres, their regular routines, and if they're not digitally enabled, then then how do they get on with their life and have appropriate support? And we're moving now into this blended model in terms of face-to-face contact, digital. So it's really important that we start to think about these issues now.
From a ground up point of view, we did a look at what I would like to see, and we've touched upon it, and some of the questions there in the chat are around people with fine motor skill issues, maybe not being able to use typing. And we really need, I think, anyway, to move to more voice control. For instance, if we had a local app, I give talks in the Irish Museum of Modern Art. If I was able to have a voice interface to an artificial, to Alexa, say I'm giving a talk on health and aging on Tuesday morning, then in the Irish Museum of Modern Art, then I think people if people locally have that flagged as an interest for themselves, then I don't, Alexa, tell me what's happening locally in my area in connection with my interests or whatever. And this is all natural voice interface rather than typing and logging into various devices. I'm just mentioning, speech and language therapists have long used digital tech to enable communication. Muir, you have your hand up there.
Yeah, just to say that I'm a public health professional, and we sometimes get a bit obsessed with local and community. And I spoke to someone whose mother was at home, and I said, "How's at home?" Like, they're very nice people, but she loves Schubert, and nobody in the home has heard of Schubert. Now, there must be 1,751 people who love Schubert in care homes, but there's only one every 3 care homes. So I think we should also be thinking much more. If you're in the Museum of Modern Art, there'll be some people who like Braque and hate Picasso and vice versa. So I think there's a great place for us sharing ideas much more and getting special. And it might be Preston North End Football Club or Queen and South Football Club or Donegal Rangers or some type of knitting, or I'm not saying it has to be culture and arts, but I think there's a great place for people not having much in common with their neighbours, and
Yes.
joining broader communities nationally or internationally.
do you think peer connection then is the, you know, a connection with peers with a common interest is more is the secret sauce rather than just local? I suppose it's connection with peers, that whether they be some obscure interest or just an interest in walking locally, that's the driver to connection and to improvement, isn't it?
Yeah, I think we have a bit of a love affair with the concept of community, but my experience has been in a highly mobile community like Oxford, people only get together when there's some threat like a new sewage farm or a nuclear waste disposal plant, which I think we should introduce frequently to bring people out of their homes and work together. But I'm a great believer in identifying what people are. So Anant's interested in the Chicago something or others, and there's probably 24 other people in England interested in the Chicago something or others, and he would be interested in that, but not necessarily the people who live along South Parade in Oxford.
What did people do before there was digital? I mean, were they all just isolated and lonely? Or did they come together? I mean, to David's point, in terms of having common interests. I mean, I think that notion of people coming together if they have a common interest has existed for a long time. I guess probably the human race. So what did people do before, and what is now the barrier that prevents people from getting together in these small groups and doing things? Or maybe they are doing things, it's just not visible to us. Because it doesn't visible to us.
I think that you know, everything's become with the digital platform, everything has become more possible, hasn't it? And that's the exciting thing. So I don't know if things were happening before, perhaps on a local basis they were. In our experience, we had 3 very specific locations of delivery in the county of Suffolk. Now I know that's not, you know, across the you know, on a larger scale, but in that multi-locational blending together in a melting pot of brave art online digital delivery, you know, people have connected with, like you say, people have different, there's a big group of people who like anime, who from Lowestoft, who connect with people from Ipswich who like anime, and you know, in Bury, and there's this, you know, and it's kind of proved on a small scale what could be possible with that wider connection. And I think the fact that we were thrown, like many groups were thrown into a Zoom delivery, you know, has really highlighted what is possible and what is possible to be delivered, you know, creative arts on a digital platform where connection is the key. Yeah.
I think in terms of channels, sometimes you've got different channels that you can switch between. You know, some are specialized, and they might be, you know, where some are more broader churches. I just want to highlight one there. Well, there's 2 comments, one from Pauline Chapman-Young about the concern that people are being ignored if they're not digitally skilled. But then there's a comment following from John MacDonald in Scotland. We've been developing the idea of digital champions, who are often volunteers willing to give their time to help people. So these are some of the responses to that. But again, it's access. But then, I mean, you know, the whole, again, coming back to social prescribing, the whole point, or one of the major strengths of social prescribing, is you've got people presenting to their GPs. COVID, of course, has stymied a lot of that. They're presenting to their GPs with what essentially are non-medical problems, and you can steer them to a worker who can provide the non-medical solution. In this case, might be digital upskilling or digital connection, to try and address those problems of social isolation. Does anyone want to comment on that, or too broad? I'm aware one other person there mentioned directories. Has anyone experience of digital directories of services?
Is that not Google?
We used Google. Tends to underrepresent poorer communities and isn't necessarily up to date, particularly for the local smaller voluntary organizations. Facebook was a platform, but Facebook has its own problems as well. The issue again comes back to proliferation of platforms and whether, you know, whether that's better, or whether you're better all adopting one system. But then how do you incentivize or enforce that?
I think there's intermediate tiers. So if I am thinking of cycling up the Banbury Road in Oxford, there's not a mosque in that part of Oxford, but there's a bridge club and a bowls club and a conservative club and a church. Now, I think at that level, they're very face-to-face organisations, and they don't, in my experience, give much thought to the people who no longer get there physically. This even before COVID. So I think we've got to help those organisations use something very simple like Weebly or something like that to get a website up. So I think there's that sort of intermediate level of organisation. They don't need a fancy website; they just need something with a contact. But I'll bet if you surveyed all the bowls clubs of England or Ireland, not many of them would have a website. So what are their former members doing? So that's just a suggestion, which we're trying to do, is to get more organisations thinking in this way about the people who used to come.
David, I think it's really challenging with online digital directories, and I've seen multiple of them and multiple versions over years run by the local authority, by the NHS, by third sectors, and I don't think anyone's cracked it. I think it takes significant amounts of resources to keep it up to date, and I think maybe the way is there a way to get third sector organisations who are providing social prescribing activities to actually input the up-to-date and correct data? But again, it's going to be key when we move back into this more face-to-face post-COVID role, where people can turn up at a library or a bowls club, and they need to know the correct time and dates when it's open.
Yeah, someone who's made the point there about people not wanting to connect digitally, which is fair enough. You know, I mean, we all been forced down this avenue by COVID. I think digital was previously mostly about information. Now it seems to be about communication as well. In terms of updating the directories, did you mention Alice, a local information system for Scotland? They have a dedicated team, and organisations on the ground are incentivized to put the information in. And I can see there's loads of suggestions going up. Pinpoint in Ontario, Canada, 211 can be accessed. Then the UK government has a directory of charitable organisations. None of these things, I suppose, are how do see that? None of these are universal, however, I think is part of the issue.
The church website is actually pretty good. And I mean, I think it lists 400,000 charities. And if you go through their advanced search link, you can find charities categorized by different intervention types. And then it's also disaggregated by different localities. And then if you click on the various charities themselves, you can get all sorts of information, contact information, addresses, phone numbers, and details about their charity as well. So there's tons of publicly available information. We're working on a separate project right now to try to make that publicly available in a slightly more accessible format, at least for England. Hopefully should be live in about 2 weeks. We'll let people know when that's available. And then there will be the option, to John's point, of the VCSE organizations. Right now it's just charities with publicly available information, but we've identified 70,000 charities across England delivering social prescriptions or different types of activities across a variety of different functions. Their total input in terms of revenue is about 20 billion if you just look at their accounts. So there's definitely a lot of activity in this space. I just don't think it's very well coordinated, but there's tons of activity in this space. And it was very, heartening to see that 70,000 number at 20 billion.
And one thing the directory of services is close to my heart is we created one with secondary schools and community organisations with our hospital in a bid to bring the hospital closer to community. And as an exercise, it really worked. Although in terms of collecting useful data, it probably was less useful. And that worked towards building a directory of services. But I think if you think of models of how to build a directory of service rather than a platform, that's probably to my mind anyway, that's more universal language. So we had ground up involvement from different stakeholders, and what is critical to our project is that we have one part-time data manager funded separately, so that person curates the content. We don't expect the providers of the services to be constantly updating it. This person chases and updates the information. It's been really challenging during the COVID era, but that's I think that seems to be a marker of success of projects that are successful, is to have the data funded separately and not expect that. But there's arguments for and against. So I think one thing we haven't addressed also is the idea of recording. Well, you have, guys, Anant and John, the idea of recording things like ethnicity, outcomes, using a digital platform. Is that been widely adopted? And Rachel, were you doing any of that in your work?
So we just have a total inclusive policy, and target our main format is that people who want to come and access what we do, it's about accessibility, and it's about making things available to anyone, so nothing specific in that respect.
Right. Yeah, that certainly raises GDPR issues in terms of tracking individuals. There are some private platforms that are exhibiting at this conference that do that, but that's up to the locals to adopt them.
Yeah, just very quickly, everything that we have that John and I are working on in terms of the observatory is from the GP practice EHRs. So we're not collecting anything new. Whatever they collect and upload is what you will see on the public observatory. So the better the quality of data recording at a GP practice level, whether that be by the GP or the link worker or the practice nurse, the more granular and better information we'll be able to display, basically. So yeah, I mean, in terms of outcomes, we haven't started, this is something that we've been having discussions about, but we haven't started formally exploring it because it's quite complex. We have 2 new resources coming up, one on social need, which hopefully should be launched by the end of next week. And then the other one on actual more granular social prescribing interventions. Because one of the blind social prescribing that we recently coded is asking for social prescribing referrals or social prescribing declined. That's the equivalent of asking for pharmaceutical prescription given or pharmaceutical prescription declined. It gives you no indication of what the presented complaint of the individual was or what intervention they got, and therefore you cannot have any idea of what outcomes to attribute to your intervention, if that makes sense. So the first step we need to take in this is to actually start recording what the presenting complaint of the individuals was, and that is very heterogeneously done across the NHS. So once that's done, then we can actually define the outcomes that we want to attribute to the actual intervention, and then we can actually start recording what intervention was given as well. So yeah, that's, I think what we're looking at here is like probably, as Muir would say, we're looking at least one WW2, which is 5 years, probably 2. So 10 years, I think we're going to need to do this properly.
You're almost describing the equivalent of an electronic application for social prescribing clients. And the other issue then is who records all this information? Is it the link worker, or who's trying to establish a therapeutic relationship? I know a lot of it's done on the fly in GP practices, but then we're trying to move away from that kind of depersonalized approach, make it a more human approach. So.
Can I just say, I think what's been noticeable for us is the fact that the COVID situation and delivering a service online has really highlighted the inequalities in different levels of care that people are receiving as well. We might think we assume that people have a laptop and can access what we're doing, but it's not been the case. And even when people have had computers and laptops and tablets to access, they haven't then always had the right support to access in a way that's been very meaningful. So in terms of face-to-face delivery, meeting needs of different people has been, is so much easier when everyone's all together because it's a very level playing field. But you start putting digital platforms in place, and the platform, it's not a level playing field, and that has been a real challenge for us to work with to enable everyone to have a meaningful experience. So that's, moving forward, that's something that we really have to take into consideration. It's really worked for some people, but for others, there are still massive gaps in actually just being able to access anything digitally in a meaningful way.
Yeah, I'm just saying, I wonder actually, Muir, at the library points of access, both for face-to-face and curating then a digital experience, but whether it's local interest or more specialized interest that will allow you to connect across the country. And the library might be a good place for all these various, or the local city councils might be a good place for all these various digital platforms of directory services, etc., to be curated. I don't know, you know, we don't have anyone from local government here. I might start to bring this to a close, if that's okay. Just I think we have until 12:50. I'm just having a look.
David, can I just say about the come back to your ethnicity comments?
Yes.
Just to say, you know, I think COVID has exposed that we code ethnicity poorly in all healthcare systems, primary care, secondary care, and it's really important that if social prescribing is going to start to address the social determinants of health, you know, we need good quality data on ethnicity so that we can be proactive and actually, you know, target specific groups. So say, for example, in London, from the Social Prescribing Observatory, we know that you know, young Black people seem to be declining social prescriptions. Well, you know, and then we can ask the question, why is that? And then we can go and work with, you know, ICSs, commissioners, and and be more targeted in our social prescribing approach. But I think, you know, that is going to be fundamental if we're trying to address inequalities with this.
Two things occurred to me listening to that part of the presentation. One, maybe a very ignorant statement. I was wondering, were you able to map it onto the ethnicity of the GP versus, you know, is there, you know, is that having an effect on the rates of prescription amongst the various ethnic groups? And the other was, of course, to see the social prescribing amongst older people, because I'm a geriatrician, and a lot of what we do are non-medical interventions and stopping medications. And, you know, when I first attended social prescribing meetings, I thought, well, this is geriatric medicine, you know, sending people for dance classes and falls classes, connecting to peer support, that kind of thing. So, yeah.
No, completely, David. I mean, and just to say, I think it's really encouraging yesterday and today. You know, it really feels like a social movement, and everyone from you know, clinicians, link workers, researchers. You know, this talk has been an example of digitally maybe not as smooth as we could have been, but everyone's heart is in the right place, and it really feels like a movement and a revolution. So I think it's really exciting for the future.
That's great. So I think there's some virtual tours are on the schedule next. So I'm going to end the meeting, this part of the meeting, if that's okay. And thank you all for your participation.